Indeed, we have become. We're in trouble. We're in trouble. All right. Like I said, this is may not be quite as long because we don't have. I just didn't want to start a new chapter, and but I did post it. If you didn't see what I was just doing before, I put the lymphatics chapter on. I'm sure while we're taking the exam, I'll get the immune stuff on for you. That we're going to start after the break. Not to, unless you're really over the top. I don't think anybody's going to be looking at it. But nevertheless, all we have to do is really summarize these areas of blood flow, a little bit of understanding how the exchange takes place, a few little odds and ends that you might find interesting, and probably that's going to be plenty for today. So this is really the last part about circulation, and it really just it's the whole idea of where it has to go and what controls it. I guess would be a better way to express it to a certain extent. Okay, and then the single most important area is the brain, and surely followed by the heart and the kidneys. Those are the big three areas. The brain it can't tolerate not enough, and it can't tolerate too much, so it always stays around the same. Okay, there is surely if there was too much blood flow, depending on the blood pressure, it could cause problems. They would be long term. It's not something that would happen right away. But when you're looking at short term, it's totally intolerant of ischemia. Ischemia is a really important word. Ischemia just means insufficient blood flow. And so the two terms are sort of like opposite each other. So we talk about perfusion being effectively blood flow. The implication is adequate blood flow. And ischemia, the absence or diminished blood flow. So those are really important terms in understanding what sort of the dynamics of circulation. So from a brain perspective, these are the kinds of things that happen for whatever reason when there's an insufficient amount of blood flow that's there. It's not that you always have to be at a high level of focus like you're studying or you're taking an exam or you're doing something very intricate. Basically, it's like anything else. You're awake, alert, sort of hearing things. You might be watching a TV show, doing some work on your computer, but you can hear, you can sort of gather in evidence from everywhere else. That's what your brain does all the time. And so it doesn't matter whether it's extremely active, like you're doing a very rigorous academic or physical chore, or you're just hanging out and doing very little. Basically, the blood flow stays the same. The circuits are still there to work when we need them. Things that impact it, okay, particularly if we have acidity and increased carbon dioxide in our system, particularly in the central nervous system, those are major triggers. And initially, what it's saying is that for whatever reason, we don't have the arterial blood is somehow corrupted to a certain extent. Because if you have too much carbon dioxide, what it's going to create is acidosis, lowering the pH. And if that's the case, there's a problem someplace. The brain, we can figure out how to solve the problem, but initially you have vasodilation. The brain's got to get itself fed. So even if it has to bring in an increased amount of blood flow, it eventually is going to get enough oxygen. So it's going to keep it relatively steady there. Okay. Now what happens, so these actually will increase circulation, but there's a limitation. We have an overabundance of carbon dioxide when that hasn't been, when the situation has not been remedied. Now all those autoregulatory mechanisms begin to fail. So it's like anything else. There's a lot of nice short-term controls. So if there's not enough circulation, there's a short-term control. If there's too much circulation, there's a short-term control. The problem is over time, short-term extra circulation, which is usually in the form of extra blood pressure, is going to damage those blood vessels. And the reality is that sooner or later, something's going to go. When I mean something's going to go, it's going to burst a blood vessel. It's going to, and when we see a burst blood vessel, we use something called an aneurysm, which is like a little bubble in a tire. And the problem with aneurysms is, they can burst and an immense amount of blood can flow out. And what happens in the brain when we have one of these they will yield at the very least a stroke and typically a significant degree of brain damage, if not death. So I mean, there are problems attended with, and we went the whole deal about high blood pressure, how dangerous it is, because a lot of times you don't know until something happens. You're actually fortunate if somebody gets a searing headache and ends up, oh my God, nothing will take care of it. They get to the emergency room and their blood pressure's off the chart. Now you can not only get it down then, but figure out what's causing it and generate some kind of treatment for it. So there's lots of different mechanisms. So if there's not enough arterial pressure, remember that map, mean arterial pressure, the vessels will dilate. Okay, and if there's too much, they'll constrict. So if there's not enough, compensate, we'll open them up more, so the brain will get fed. If there's too much, we'll constrict them, so those vessels won't get damaged. And again, it's always about the extremes. And again, that's an important term. Not that I'm going to ask you what syncope means, but it's a term you're going to hear a lot, depending on if anybody in here is going in a clinical field. And obviously, not everybody is. But when you hear this, once you see the word syncope or syncopal episode, that's code for they fainted. And again, that's part of the problem when there's insufficient blood flow. Imagine we don't usually associate it, but fainting can occur almost any time. Fainting's odd, to tell you the truth. I've seen people will faint hysterically about things. They'll see something like maybe they can't stand the sight of blood or they can't stand needle. My daughter's like that. If she sees a needle, particularly if it's directed at her, I mean, they could take blood, but she just will not. If she sees a needle, she goes out. And I had one of these lab techs say, I'll just, why don't you lean your chair back? No, she's not going to faint. They all say that. And the guy looks at me and goes, she fainted. I said, we told you. Moral of that story is when somebody tells you something, listen, particularly about that. If someone's going to faint or someone's going to get sick, there's a reason parents, loved ones, significant others say that stuff. So this is the idea. Fainting can occur for a lot of things, but excessive, that would be a prodrome for shock. Would lead that. And when it's very, very high, cerebral edema is effectively fluid in the brain, but I would be more worried rather than just some fluid leaking out as to something bursting. More than that. And I remember seeing people like this. They come into the emergency room, what we call malignant hypertension. Their blood pressure was so high, off the charts, that literally we had to immediately start to treat them aggressively with agents to get the blood pressure down to manageable, just because they were at risk of having most likely a stroke or a heart attack. And the medicines today are better, but back then they weren't necessarily that great. But I mean, that was we got to do something now. That was an immediate emergency. Skin's interesting because it's a way we dissipate heat. Okay, so effectively, I mean, sure, it's going to do what it's supposed to do, and again, in response to oxygen. If for whatever reason that area of skin, because it's being utilized a lot or is exposed to the sun, or figure out some reason, it's going to be, there's going to be subtle corrections whether it needs more or less oxygen. But really, the big players here are regulating body temperature, as well as being a reservoir for blood. Body temperature is just whether you're working out, whether something has occurred, whether there's an infection or you've developed a fever. Part of what we see is your skin. Initially, the sympathetic nervous system will deal with it by perspiration. And as the perspiration evaporates, you cool. But that's not necessarily sufficient when you deal with someone with a high temperature. Part of it, it's almost like the heat's radiating off them. If they've done a very vigorous physical activity. And so you're diverting blood flow to the skin just because the heat's there, and as it effectively more or less radiates off, it'll dissipate somewhat in their system. That's a really important function. And this is to understand, and I had asked the other class about this, a large percentage of your blood comparatively is all about your skin. So you have your systemic circulation, which we're all familiar with, taking care of the organs and muscles and all like that. About 5 to 10% of your blood is effectively in support of the skin. That's a pretty significant number. So you can imagine how much heat can dissipate or things like that. So there's a fair amount of blood flow that goes to the skin. And you're going to see at the end of this, I have a little discussion about something that you probably, and I understand you didn't cover in anatomy. I just want to mention it in passing because I think it's important. Is that you actually have a set of veins that are dedicated really to the skin. You have most of your veins when you're playing name that vein, femoral vein, brachial vein, etc. Those are veins that service your muscles. There's a whole series of veins that we call superficial veins that basically service your skin. And it's interesting about them how we utilize them. But we'll more of that as time goes. That's sort of like the little nugget I put at the end. Not that you have to know about that stuff, because to me it's something I would cover if I was doing, and it's not trying to be overly critical about Dr. Robbins. So there's so much to cover, you got to pick and choose. It's because I'm very familiar with that stuff and researched it and lectured about it. It's sort of my little niche, so to speak. So blood flow through these veins and venous plexuses under the skin, body temperature, and look how much it can vary by a factor of 50. So think of how much heat you could dissipate. Yes, the sympathetic nervous system is going to play a role, but it's temperature receptors. And it's not just because you're out in the sun too long. Okay? It's not that type of thing. It's not because, a lot of times we see these factors with a variety of things. I commented to you about the case of malignant hyperthermia with a football player that killed them. I mean, these are mechanisms that are really important to dissipate heat. And that was just from a blood pressure, from a formerly legal diet medication called ephedrine. So heat exposure, fever, exercise, all of those things. And is there some underlying feature like medications? Okay. And the hypothalamus involves this, and it basically stimulates the vessels in the skin to dilate. And so it'll radiate off. And it's really a good word to describe it. And by the same token, it'll constrict. And so, and this is, understand when the vessels constrict, and this is the example of cold weather, what causes that, the rosy cheeks or, being able to, coming from a cold and you go, oh my goodness, you must have been out there too long. The spasm has effectively even trapped some of the blood, that's with a quote unquote rosy cheeks, because effectively it almost sends the vessels into a spasm. And that's where some of the problems are vis-a-vis things like frostbite. The fact that there's blood in there, if it's unable to move or it doesn't have adequate oxygen, it's not helping. So you have to look at those kinds of things. Hopefully we are done with all that stuff. Please. You saw me go on a rant this morning, everybody's wearing shorts. It's like, oh my God, it was cold. It was 40 degrees this morning. The morning group's coming in there like they're out for the break. I know it's an age thing. Okay, interesting. Pulmonary circuit, different. It means the reverse. The arteries are more like veins. The veins are more like arteries because one's deoxygenated blood, one's oxygenated blood. And look at the difference here. I mean, you dissected a heart. The muscle's 3 to 4 times, and it generates that 3 to 4 times thicker muscle, and the ventricles generates an immense amount of pressure. This is a low pressure circuit because the first thing it encounters are veins, not arteries. And arteries inherently have a little bit more resistance to those big pressure changes. This is not the case here. And they're very much opposite. And this is the first area. Low oxygen levels cause vasoconstriction. High levels promote vasodilation. That's the opposite. And this is something we're going to see when we talk about respiratory, and that's not going to be in a while. That'll be probably 2 or 3 weeks after we come back. Toward the latter quarter of the term, we do respiratory, digestive, urinary, and repro. It's one of those great things our body does that really can get you in big trouble. If that makes any sense. We have so many great backup systems. We've got an extra kidney. Great. We've got 2 lungs. Great. We've got all sorts of tissue. We've got spare parts everywhere. One of the things that happens, and it plays a trick on people who have lung disease for whatever reason, Whether they got it because they smoked like I did for all those years. Thankfully, I don't have the lung disease. Or whether it was something that by choice or environmental or problem or a disease entity, notwithstanding, what your body does is right here. When your heart's pumping out venous blood to get oxygen, it directs it to where the oxygen is. It dilates the vessel to the oxygen-rich areas. And the flip side of that happens on the respiratory side. On the respiratory side, it directs the blood to areas where what they call bronchioles, the little air passageways, are greater, so it can get rid of the carbon dioxide and bring in more oxygen. And that may sound wonderful, and it is. The trouble is, it affords everybody a false sense of security. And you will come to know people over the years, as many of us have, and the same is true for the kidney. All of a sudden, they'll come in and they just got over I had a terrible case of flu. They go and see the doctor, they do some tests, and the doctor turns around, look, I'm glad you got over that pneumonia or that flu. I know you were really sick, but you're going to have to be on oxygen for the rest of your life. It's like that. They reached a tipping point where those compensatory mechanisms are insufficient. And usually you're about 80% gone. The same is true for the kidney. You have two kidneys. You only need one, and you only need about a quarter of that one. When you get to, that's effectively an eighth of your total kidney that you're born with, kidney area. That's a lot of functional kidney space, if you want to think of it that way. Imagine how much, that's the false sense of security that someone will come in and say, I really have not, I'll get this pain back here and all this, and they know, or mostly they're diabetics. And the doctor will turn around, I've got bad news. I mean, after this last episode, now you have to be on dialysis for the rest of your life. But last week I wasn't. That's because all of those safeguards, all of those backup systems, all that redundancy that we have magically disappears. And it's one of the fascinating things I find, and all it argues for is for many of you who will be in clinical fields, and even for your loved ones if you're not, is basic. Make sure they keep getting checked if they have underlying disease. If they're a diabetic, you can't wing it. If they were a smoker or a drinker, or they still are. I mean, it's hard to convince people because sometimes they don't want to hear, like anybody else, you don't want to hear bad news. It's like sometimes I don't want to pick up the phone when one of my kids calls. I used to joke, hello, how much? Not how are you? How much? Your parents may be like that right now. Okay, blood flow to the heart is influenced by the pressures. We know all that. If you didn't know it, when your heart contracts at systole, the blood can't get through. It squeezes those vessels, the coronary arteries. Okay, we have to rely on the stored myoglobin for oxygen. And when they rest, now that pressure we talked about, that backwards pressure, forcing the blood through the coronary circulation. So part of that thing that I showed you called the dicrotic notch, okay, that has something to do with the heart, is all about that as well. It helps to allow. Oops, sorry. So at rest, blood flow is about 250. Typical myogenic mechanisms. In other words, it will divert it to certain areas that are there or constrict it when it's not needed in a particular area. The heart basically controls itself. But strenuous exercise, look at that can do it. Local accumulation of chemicals will dilate it. We saw that on that chart 3 to 4 times. Why is it so important? 65%. Unlike most of the cells in your body, if you did not know it, and we'll get to that when we look at respiration again, when we look at respiratory and physiology, and like I said, it's a couple of weeks, so even though I understand you're going to do respiratory anatomy when you come back in the lab. Most of your cells, when the blood goes from artery to venous, it gives up, there's 4 hemoglobins and it only gives up 1 oxygen. So you have 4 oxygens riding on the hemoglobin, it only gives up 1. So even deoxygenated blood is 3/4 filled with oxygen. Not so here. The heart has a greater amount of demand. It's using 2/3 of all the oxygen that's available on those cells. That gives you an idea of its demand. That's there. And this has to do with really, it surprises you that the aorta, okay, even though it's certainly the blood flows the fastest and it's slowest in the capillaries, but it has a lot to do with cross-sectional area. I'll show you the chart. So even though you have, effectively, if you want to look at what's going on, and here's the velocity very fast, if you want to look at it comparatively, you only have one aorta that has very, very little surface area compared with all the capillaries where blood's flowing extraordinarily slowly, but it has a ton of surface area. So what does that tell you? Is that this is the area, it's flowing slowly so it can accomplish the exchange, and where all the surface area is. These are basically, again, why we call them conducting arteries or distributing arteries. They're conducting because they're not doing any exchange. Distributing arteries lead into those capillary beds where we actually do them. That's there. The whole idea of redistributing it is a fancy term called vasomotion. Motion just means motor, and it's motor to the smooth muscles that control the relative diameters. Opens them up, closes them. Easy enough to describe that. This is the whole, and this is the same thing we talked about in AMP1 in the very early days of it. How do things move? Basically, by diffusion. They follow concentration gradient. The gases, oxygen and carbon dioxide, whether they're in your lung, we call it pulmonary, okay, and a better pulmonary respiration. And then in the tissues where we will call it cellular respiration, all respiration means oxygen going in one direction, carbon dioxide going in another direction. The essence of the respiratory system is this. It's a simple sentence. It's here. I love it. In with the good air, out with the bad. And effectively, that's what's going on. In your body, you're bringing in oxygen in the lungs and you're expelling it. In the cells, you're expelling the oxygen from the capillaries and bringing back in the carbon dioxide. You're exchanging one for another. And it all relies on partial pressure. Partial pressure is the same as concentration. So we're not talking about 5% and 1%, and it's going to go from 5 to 1 because it's more concentrated. Okay. If it's partial pressure is 20 here and 2 here, it's going to go that way. If it's 5 here and 1 here, it's going to go that way. And that's really how oxygen and carbon dioxide. So partial pressures are the equivalent of that. So we're still concentration. The difference with dissolved stuff in fluids, okay, is they rely on traditional concentration. So whether it's how many milligrams or how many grams percent, whatever measure they're using for that. So the beauty of oxygen and carbon dioxide, they're small, they're non-polar. We talked about that in AP1. That means they can move, eat. They can just fly through those membranes, no problem. And you'll see that when you get to respiratory, in about a fraction of a second, your blood's oxygenated. It's all boom. It's meandering its way around over a couple of seconds. That's another one of those safeguards. Oh, even if your lungs are bad, you've got a hole. It's like the lazy river. We can just and finally pick up the oxygen. It's another one of those. Thanks a lot. Safeguards. And I'm not saying it facetiously, but again, that false sense of security. If you're going into, it doesn't matter. Everybody has people who get sick. So if you're dealing with healthcare in any area or not, it's one of those things. Well, I never felt better. Yeah, I had to be on dialysis. I never felt better. Why have to be on oxygen? Because oxygen bottles drive me crazy. I see people in the casino with oxygen bottles in the smoking section. Are you kidding me? Boom. Nobody wants boom. Okay, so water soluble, you'll see. In the kidney, those little holes. We talked about the different kinds of capillaries. Effectively, that's filtration. That goes on. And yes, there's active transport. So basically the way that they move, they diffuse. And diffusion, again, can be concentration gradients or partial pressures of gases. There's openings for water-soluble things to make it through. The fenestrations, like in the kidney, allow a greater degree of filtration. They're larger. And sometimes we use active transport. When we get to the kidneys, you'll see how we utilize active transport a fair amount to basically reclaim stuff that was filtered out, but we really need to keep. And you saw that illustration before. Those are the fenestrations. You can see the clefts that are there. So there's a lot of different, those are really the equivalent of pores. there's a lot of, I mean, it's very, I'm trying to think of the best way to express it. If you look at this, and I'll take you to the next slide, even though it's a capillary, pressure is so critical. It's a tube. And the notion that sometimes you have to do away with is when fluid, when blood's flowing through the tube, the pressure isn't just going in a straight line. It's pressure. It goes against all the areas. When you feel something, if you feel a balloon, the pressure is all about the balloon. It's not just right in the middle where the pressure is. You can feel it pushing on all the margins. That's what keeps it inflated. The same is true for a blood vessel. So pressure is coming from the central area and pushing against all the margins. That's the force that pushes stuff out. And you can see there's a lot of openings that are there without going crazy over that. So the fluid is forced out of the capillaries at the arterial end because it's higher pressure, as you'll see, and returns at the venous end because you effectively reversed it. Okay. And so a lot of that is what you're coming to with all this. They're talking about relative fluid volumes, interstitial spaces, and bulk fluid transfer. Suffice it to say there's two players. Hydrostatic pressure, blood pressure. The force not only pushing it through the vessel, but pushing against all the sides. It's offset, again, by something we talked about early in AP1. That's why I do the way I do it. That's why you can tell the incoming students next year who are endeavoring to go into the same fields, you're stuck with him again. Tell them I'm mean, I'm evil, and I have a wonderful sense of humor. It's okay. We'll know you're lying. And I have wonderful taste in clothes and a snappy dress. That was Grace was giving me the old facetious smile. Admit it.
One day you'll break her.
Yeah.
May not be today.
She's not going to be tomorrow either. Because I don't see her. We have time. Nevertheless, the colloid osmotic pressure, all those wonderful proteins, they're holding on to water. That's what proteins do. Part of their job is to hold on to stuff. So sometimes they transport stuff that isn't water soluble. The colloid osmotic pressure is the force that's pulling it in. They offset. At the arterial end, the hydrostatic pressure wins. At the venous end, the osmotic pressure wins. Why? Because all that stuff, the fluid has been pushed out. So it's going to lose pressure. It's like this. At the start, the hydrostatic pressure is 35. Remember, it started at 120. And these vessels are progressively smaller. At the venial end of the capillary bed, it's only 17. It's like, it's half as much as it was to start in the arterial end. Why? Because fluid and other materials have been pushed out. You'll see when you get to the kidney, and that's really towards the last month or so, few weeks of the class. At the kidney, it's a higher pressure because it's designed to be a high pressure system. Because actually we're pushing fluid out of arterioles. It's a little bit different. Before we get into it, it's designed to be high pressure. We get to that when we talk about the kidney. And so I'll show you the summarized like this. The osmotic pressure is a sucking pressure to pull it in. Effectively, the hydrostatic pressure pushes it out. And they go through all this stuff for net pressures and blah, and blah. Here it is. At the arterial end, that 35 pushes it out. The proteins account for 26 to pull it back in. What happens is there's some proteins in the interstitial fluid, the fluid outside the capillaries, that also will tend to pull it out a little bit. So the net flow of pressure outwardly, they call the net filtration pressure, is 10. That's sufficient to push the fluid out. As you push the fluid out and whatever in there, you get to the other side, and now that effectively the blood pressure is down to 17, and it kind of stays around that number all the way back in the veins as it makes its way back to the heart. They stay around 15, 17. You still have the same amount of proteins that were there before. That doesn't change because those proteins can't make their way out. They're too darn big. And okay, we do have some proteins in there still pulling it out, but it's not enough. It doesn't change it dramatically. It was 10 being pushed out on the arterial end. It's 8 being pulled back in on the venous end. That's good. It's enough to pull it back in. And that's really what happens. For whatever reasons, edema means there's too much fluid in that interstitial area. There's really two major reasons it can come from. And it depends, and it's a good clinical nugget. Is it one-sided or both-sided? If it's both-sided, again, the body's very bilateral and symmetrical. Two eyes, two ears, two hands. I know there's rights and lefts, but we're identical on both sides. We're mirror images. That's bilateral and symmetrical. When we see something happening on only one side, we always look for asymmetry. What could cause fluid? And basically, fluid comes from excessive pressure. If you had a blockage, like a clog in a blood vessel, if you had a tumor, we see one-sided swelling in pregnancy. Typically, the baby is more as sort of shifts to one side or the other, and interestingly, it's more frequent, to the left than to the right. The typical pregnancy. Those are effectively all variations of mechanical obstructions. Maybe with the exception, now you have to, and there's injuries, and with a blood clots don't necessarily play favorites. So sometimes it might just occur on one side, it hasn't occurred on the other side. Now, so when you see it on one side, again, I'm not going to ask you this as a test question. This is an observation. On the road, this helps you with your fields you're going to. When we see edema, fluid accumulating, typically in the lower extremities because of gravity, that's bilateral and symmetrical, it's on both sides, it's got to be a central player. The heart has failed and fluid's backing up. If the right heart fails, the fluid's going to back up. I mean, sometimes it's so bad you can actually see the jugular veins distend. Okay. But most of the time, gravity, so it may be in the abdomen, but it's going to take it eventually down to the lower extremities around the ankle, top of the foot, as you'll see here. It could be the kidneys because they're responsible for making sure we get rid of fluid. If they start to fail, you have excessive fluid in the system. It could be the liver because the liver is making all those proteins to hold the fluid in. If it doesn't, it comes out. So, I mean, that's the distinction. So something has caused fluid to extravasate. So, yeah, it could be as simple as varicose veins. And typically they're due to incompetent valves. And I'll get into the one distinction I wanted to tell you about. Blockages, but heart failure, high blood volume is kidney. So that's it. You know, they're painting with a broad brush here, but it's not supposed to be a clinical manual. So it could be inflammation, so it could have to do with infection. And the other thing, and really where we see it a lot is with blood clots. Blood clots are dangerous. Okay. And the one that you worry about is called a DVT, the initials, deep venous thrombosis. That's the kind. Thrombosis is the clot. What happens to thrombi, the plural, they can break off, and when they break off and travel someplace else, we call them an embolus, and the plural is embolon. And what happens is, if they start in a deep vein, the veins just get bigger and wider, all the way back to the heart, and then they get through the heart, and when they start to narrow, they're going into the lung. Remember your circulation? So in by the vena cava, and typically they're coming up through the inferior vena cava, they go through the right atria, right ventricle, where they start to get narrow again, in the pulmonary trunk as you get down to the pulmonary arterioles. Unless it's a jumbo clot, and those are really dangerous. And so there's different, and now you may not be making enough protein, malnutrition, liver disease, kidney problems. So think of that's the distinction that are there. And so what happens when it's mostly fluid, we call it pitting edema. Okay. Then there's other things. There can be problems with the lymphatics. We're going to look at those when we come back from the break. But pitting edema is just that. You'll see the illustration. Basically, you put it, they're due to the top of the foot. Typically, I would do it over the medial malleolus. It's a pretty distinctive bony on the side, basically your ankle bone on that side, you might remember. And you press firmly, and you take it away, and you see how long it takes to fill back up. If it pits, meaning you can see that, then you gauge it by how long. I mean, you'll see it. You could walk out of the room and come back in. You could go walk out of the room, go on the chart, come back in, it's still there. It's crazy. That's +4. So if you see something and then you learn the parameters to grading it. understand that sometimes you'll have, well, it didn't pit. It must be getting better. The longer there's pitting edema, all the proteins that are in there, all the solids that are in there begin to consolidate and it gets thick. We call that non-pitting edema. And unfortunately, so the longer the edema is in there, the more likely it is to firm up. And that's even worse. Now that's never going to get back into. There's problems attending with that. So typically it starts as pitting edema. Sometimes it starts as what we call lymphedema. And that's something I'll talk about a little bit when we look at the lymphatic system, which is sort of the introduction to the immune system when we come back from break. Yeah, the classic example is somebody who's had a mastectomy, and they always do a lymph node dissection. Because the tail of the breast, okay, goes into the axilla, and if it's going to metastasize, and they do a lot. There are rapid metastasizers there, so you always at the very least, you'll biopsy that to make, if you just do a lumpectomy to see if you have to do a mastectomy. And if it's in there, and then what happens post mastectomy, you'll have this massive amount of lymphatic. The lymphatics are not there. The only way you get the fluid out is to mechanically pump it. And people they'll pump it out. They'll go to an outpatient facility. They'll wear a sleeve on it throughout the day. They may have to go in there frequently, multiple days a week, to do this. It's unfortunate, but it's the reality for certain people that are there. And as you can see, because the longer there's the fluid in there, it impairs all of these problems, circulatory problems that are attendant. Now, you can compensate it, but very often the kidneys are bad too. So you can't do much with that either. This is the last part about the veins. Without going through all those, that's typically in lab, you focus on the arteries, and you spend less time talking about the veins, those blue guys, those guys. See, there's two vein systems. There's a superficial system and a deep system. The skin, like I said, 5 to 10% of your blood in the skin. You have veins that are designed to drain, and that's the term we use with veins, the skin. All those named ones, femoral, brachial, radial, okay, all those veins are deep veins. They drain organs, muscles, deep structures. They're the ones you worry about if a clot forms in there. That's what we call DVT, deep venous thrombosis. The ones on the surface, because they're on the surface, are called superficial. You're familiar with them because that's where we start IVs. That's where we draw blood. Because what happens is, particularly if you have to stick things in there repetitively, it can cause clots to form. Clots that form in the superficial veins don't hurt you. They hurt you because they're painful. They hurt you because they get inflamed. I was telling the other class, I was getting sticks so many times between 1998 and 2000, my arms literally turned black. You don't notice they're not black. So they'll get better if you correct the underlying problem. And over time, we call it recannulating. New veins will form and the holes will open and blah, blah, blah. Magic, black. But the idea of those kinds of veins is that they're painful. It's called a superficial phlebitis. It's very common with people. People have blood clots in the deep veins, they're generally silent. And a lot of times the alarm is they develop a pulmonary embolus and they can't breathe, they collapse, they're ill, or they die. Superficial phlebitis is typically very painful. That's why it's the kind of thing you see the patient in bed, because that's really where they're at the greatest risk, why they have those intermittent squeezers, the intermittent compression devices, to try to prevent that. You see a patient in bed, take the time to look under there. And all of a sudden you see him in bed, and the next morning, it's you're there and you had him yesterday morning and now it's more swollen or more edematous. Even if it's, well, does it hurt? No. In the back of my mind, I'm going, I'm asymmetry. I wonder what happened. And that's the kind of thing you call that to somebody's little teaching point. So the veins that you use, this is the way, the main veins you start IVs in, you hold your, like this, you'll see them up here. This one's called cephalic, this one's basilic. The one on the thumb side toward the head, cephalic. The one toward the bottom, basilic. If you hold them up this way so they're easier to see, this is a very useful vein for starting IVs. On that, the cephalic vein or the basilic, they both kind of flow into each other, and they sort of meet in the middle from the cephalic and basilic side over here where you draw most of the blood. It's called the median cubital vein. They're all superficial veins. It doesn't matter. You stick it in there and somebody misses, and oh my God, it's not life-threatening. Nobody will let you, the patient will be upset, but they won't die because of it. So understand that there, and it's something, because I spent so much time studying it, and very interested in veins and blood clots and varicose veins, because they were a contributing factor to my dad's inability to survive heart surgery, because the veins that we use are superficial veins when you do open heart surgery. Yes.
So with that, I noticed that like their veins are tough. Like when they get like blood drawn or something.
Right.
What makes that?
I don't know that the easy answer is there's some people who hereditarily have veins that are problematic. Most people do. Most people do not. A lot of times they've been told that. See, I hate that. I go in and get blood drawn on a fairly regular basis. I mean, not so much now as I did years ago. And they'll go, do your veins roll? And I look at them, do you know what you're doing? I mean, a lot of times it's hate to use the word incompetence. People who are less than competent, it's like a self-fulfilling prophecy. I'm not sure, but if I don't get your vein because they'll say, oh, you moved or your vein rolled. I don't buy it. Now, if someone has a genetic problem, hereditary problem with bleeding or things like that, to me it argues a little bit more in that sense. I'll tell you the same thing I told the other class. The three things that avoid that problem with veins are the same three things that avoid complications in surgery. Technique, and technique. Learn to do it. That's what they teach you here. But if you're going to learn to stick people, learn the method, do it properly, rinse and repeat. And you'll get to the point where it's like a rhythm of doing this. Some people are just a more difficult stick than others. I used to stick the drug addicts. They'd used up all their veins. What made their veins hard to stick was their scar. They actually hide veins. I need to start this IV. You use plain language sometimes to talk to people, or you're going to die. I need a vein. Give it to me now. I won't tell. It was really tough. I spent, we had a very large population of alcoholics and drug addicts and outpatient treatments. And I was the one who got, we need you to come up and do the stick. I was good. Everybody has a gift, but not anymore. But I don't have any good answer to your question, in short. But I think a lot of times people have been told that they have hard veins because the person who tried to stick them wasn't so good at their job. So I'm like that. I have what's called the 2-stick rule. You get 2 shots to get my ball. If they miss the first one, I'm okay. It's because people have bad days sticking people. And if they miss the second one, I'm going, well, I'll try again. No, you won't. 2 sticks. Get somebody else. But no buts. You could go out and tell me I have a real pain in the ass patient. That's fine. I'm good with that. But the reality is I have a 2-stick rule. A lot of people do. You get somebody else because maybe you're having a bad day. I'm not being judgmental. I'm not going to sue anybody. I understand stuff happens. I mean, I've had that. I told the physician, I said, well, you get it. He goes, well, I'm not that great at doing those. I said, get the IV team. Well, you're going to have to wait. I said, I'm not going anywhere. I was having an outpatient procedure. I don't care if you need the room, get it done. I'm the patient you don't want to have. Doctors make the worst patients. Goodbye. See you. Okay, I'll restart now. You convinced me. I'll see everybody tomorrow. This time. How many times do you have to restart your computer in this world? Oh, who's that?